Hello and welcome to another session of Clinical Physiology. I'm Dr. Junqiang Ma. Today, we are going to talk about pain. After this session, you should be able to describe the transmission of pain. Compare A delta fibers and C fibers. Define referred pain and explain clinical significance of referred pain. Pain is pretty important for us, and it is a defense mechanism suggesting something is wrong in our body. Pain can be classified as somatic pain and visceral pain. When we sustain a joint injury from a spot or a cut in the finger, the pain from the skin, joint, or muscle is somatic pain. If we have pain arising from a visceral organ, for example, the gallbladder, heart, or stomach, it is called visceral pain. So how do we feel pain? Well, there are special nerve endings that initiate the sensation of pain in our body. These are known as nociceptors. They are cutaneous receptors that are specialized to detect noxious stimuli, like tissue damage, very hot or cold temperature, or extreme pressure. There are two types of nociceptors. The first is the A delta fibers, which are very small myelinating nerves that produce fast, well-localized, sharp pain. Then we have the C fibers, which are smaller and are unmyelinated, and they generate slow, poorly localized pain. C fibers produce a burning or throbbing type of dull pain. The nociceptors can also be referred as the afferent nerve fibers, because they convey information to the second order of neurons in the dorsal horn of the spinal cord. Then the second order neurons quickly decussate or cross over to the other side of the spinal cord, and the signal travels up to the spinal cord to the brain. It travels via the spinal thalamic tract, which is the main pathway for transmitting pain information to the cerebral cortex. The term thalamic implies thalamus, which is an area of the brain, so this tract will head to the thalamus. More specifically, these fibers go to the ventral posterior lateral nucleus of the thalamus, where they synapse with the third order neuron that carry the pain information to the somatosensory cortex. Here is where the location and discrimination of pain occurs. Please note, pain in the right side of the body is processed in the left side of the brain and vice versa. Okay, the contents above are somatic pain. It arises from skin, muscle, and joints. It is superficial and well localized. How about visceral pain? Visceral pain is the pain sensation from the internal organs. It is poorly localized. Lack of blood supply, chemical stimuli, spasm, or over distension of hollow organs will easily cause pain. The usual associated visual responses are nausea, vomiting, anxiety, etc. When talking about visual pain, there is an interesting but very important type of pain which I should mention. Let's see a case first. A 55-year-old man presents at the clinic with pain in his right shoulder. After a thorough examination, the doctor says that the source of his pain is his gallbladder. The patient is very confused. His gallbladder isn't in his shoulder. So what's all this about? Is the doctor right? Yes. the doctor is right. Such kind of pain is called referred pain. It comes from injured organ or tissues, like the gallbladder in our case. But the pain is found somewhere else, like the right shoulder. The precise mechanism that causes referred pain has not yet been settled. The most acceptable theory is like this. When a patient's gallbladder is inflamed or infected, it sends signal through the visceral nerve fibers to the dorsal horn of the spinal cord. However, our visceral lacks specialized pain neurons. That same dorsal horn also handles signals coming from the shoulder skin through skin nerve fibers. Signals coming from different directions cross-talk with each other. Well, when pain signals from the gallbladder goes up to the brain interprets it as coming from the shoulder. Recognizing referred pain patterns allows us to make diagnoses that may otherwise be missed. One more thing about referred pain, and that is the difference between referred pain and radiating pain. If a patient has a headache and the headache goes down to his neck, we will call that radiation or radiating pain, or more specifically, headache radiating to the neck. If a patient has pain in his lower back, and he can feel it going down to his button and down the back of the thigh, we will call that lower back pain radiating to the buttock and leg. Or if a patient has a heart attack or myocardial infarction, the pain is not in his chest, but on his shoulder. We call this referred pain, or ischemic cardiac pain referred to the shoulder. So that is the difference. Referred pain doesn't have a focus and involves a wider area. It is away from the organ that actually has the problem. So, in summary, pain information is transmitted from somatic tissue or visceral organ to the central nervous system via nociceptors and a series of neurons. There are two types of nociceptors, A delta and C fibers. A delta fibers are very small myelinating nerve cells that produce fast, well-localized, sharp pain. C fibers are smaller and unmyelinated nerve cells, which generate slow, poorly localized pain. Referred pain comes from injured organ or tissue, but is felt somewhere else in the body. The radiation pain has a focus and is more extensive. Thank you, and see you next time.